Hello, and welcome to the Clinical Care Options Psychiatry podcast. I'm Nicola Hansen, Scientific Director, here with Dr. Robert Cotes and Dr. David Goldsmith, co-directors of the Clinical and Research Program for Psychosis at Grady, part of the Emory University School of Medicine in Atlanta. This episode is entitled Reaching Patients Where They Are, Experience with LAI Antipsychotics in Community Practice. This podcast is part of our 2024 program, Liberating Stability, a deep dive into long-acting injectable antipsychotics, supported by educational grants from Indivior Incorporated, Otsuka America Pharmaceutical Incorporated, and Lundbeck, and Teva Pharmaceuticals. This full certified educational program includes medical minute presentations with downloadable slide sets, interactive case challenges, and a downloadable reference guide, authored by several expert psychiatrists and pharmacists to provide a wealth of information on incorporating LAI antipsychotic agents into your clinical practice. Please visit the show notes for information and links to these additional activities. Now, let's get started and hear what Dr. Cotes and Dr. Goldsmith have to say about their experience with LAIs.
All right, so I'm here with Dr. David Goldsmith. This is Dr. Robert Cotes, and today we are talking about long-acting injectable antipsychotic medications, which are really an important cornerstone therapy for many people living with schizophrenia these days. And I think that many clinicians have some hesitation to even ask about long-acting injectables in the first place, or when they do talk about long-acting injectables, sometimes the conversation, maybe somebody says kind of no initially and it's not brought back up. So David, I'm curious, how do you typically talk to your patients about LAIs and kind of what strategies work, and what do you think?
Yeah, I think you bring up a couple of really important points in the question. These really are key and an important option for patients. And, I'm sometimes surprised at how some patients are very open to them. A lot of the time patients are quite reticent to have to come in and get a shot, and the idea of the injection can be pretty challenging for people, whether that's a fear or maybe they were traumatized by having injections when they were, on inpatient units in the past. You never quite know when and why patients may come to you and sort of shut you down when you bring this up. But ultimately, I think it is really important to bring up and to continue to revisit it over time. I think ultimately, as with most things that we do, I think really trying to tie this into recovery and to be very recovery oriented and to think about goals that patients have. And, if they're having difficulty meeting those goals or really thinking about functioning, this may be a really nice way to introduce this idea of, I think we could be making more progress to whatever your goal is. And this may be one path to do it. I think remaining pretty focused on recovery outcomes is pretty key here. I'm curious what you think.
Yeah, I think that's one of the most important parts, is really sort of meeting people where they are. And for many individuals, symptom amelioration is not the top goal. The top goal is getting back to work or getting back to school, having meaningful relationships with other people. And really, in order to have a conversation that links the medication to the goals, you have to have a clear understanding of what the goals are and really sort of systematically evaluate that and make that a part of the, pretty much every interaction that, you have with somebody, ideally. And for some people, it might very well much be about, getting rid of the voices or reducing the volume of the voices. But I agree that, for many people, the most compelling approach is to help them think about the medication in a way that moves their lives forward in some way that they're hoping for. And you also made a really good point about how it's not a one-time conversation. Like, it's very difficult to kind of just walk into a room the first time you're meeting with somebody and say, well, what do you think about trying a long-acting injectable antipsychotic? And sometimes you can be successful and other times it may be more difficult, but the ongoing conversation is really important.
Yeah, I can think of one patient who I work with who, we had some version of this conversation about a long-acting injectable for a couple of years, actually. And, he would take oral medications, and the oral medications would work quite well for him. But, at some point he would feel like he's doing better and he didn't need to take them anymore. And, things would start to get a little loose for him, and he'd have issues with his job and with his kids and with his partner. And it was really challenging. And then we talk about it. He was really, I think, afraid of the needle was his primary concern. And so he sort of kept going with prescribing oral meds and achieve stability and then lose stability. And it finally was, I think he started having some real issues with his partner. And I think that was, that was really important to him. And I think that we actually had a family meeting where she came to the appointment and we had a conversation about it. And I brought up the long-acting injectable again, and this time he was open to it. And she came with him to that first injection so he could get support because he was really afraid. And he's been on a long-acting injectable antipsychotic now for close to a year and has really achieved long-term stability, both in his symptoms and in his personal life and his goals. He's working full-time right now, has this relationship with his kids. It's really made a huge difference for him.
When you talk to him about the long-acting injectable now, like, how does he view it? Like, what does he think about it?
Yeah, he really likes it. I mean, it's really remarkable how much of a 180 it's been for him. He kind of, I think he likes coming to clinic once a month. He's developed a really nice camaraderie with the nurse who he sees every month. He enjoys coming in to see her. And I think that, he is able to see, the stability and the ability to achieve the goals that he has in his life on this. And so, when I see him, we talk about that, and he's really proud to tell me how long he's been in this current job and what he's been up to with his kids. And, occasionally I'll ask a little bit about what the reticence was initially. And, he pretty upfront was saying that, it was sort of all a lot of fear, and he had built this thing up in his head that may not have truly been founded. And I think he's been really happy with the decision to go with the long-acting injectable.
You brought up a really important point about coming to the clinic once a month and building relationships with the nurses, and also by extension, sort of having a regular time to come in and maybe get other services from the clinic. How much of a role do you think that's played in where he is now?
Yeah, I think it's played a big role. I think that it sort of was almost like an open door in a way to seeing what else was available for him. He'd come in to see me, and we'd have sort of, we've spent a long time building the relationship together and building the trust and sort of that really key engagement piece. But, I think this is sort of the first time that he kind of had an opportunity or an acceptance to see what other options there were for him and the services being offered to him in the clinic. I think at some point he saw our career counselor, our supported employment specialist, and that was really helpful to him. And I do think that initial decision to come in more frequently, to start to get the LAI was pretty key for him. I'm wondering, I mean, I think that is I think it's a pretty clear success story. I'm wondering, in your experience, what some more of the challenges have been, and when you face patients who you really think would benefit from a long-acting injectable, what are some of those common challenges, and how have you started to navigate them with folks?
So I think, one of the things is the initial, sort of conversation and engagement around the decision around taking the long-acting injectable is a really important part of all of this. So I think there's sort of like what do you do before you start one? And then when people are on them, how do you maintain that momentum, and how do you, sort of keep it going? Nurturing the motivation, I guess, is one way to think about it. And some of the things that I think can be a little bit challenging when people are on the long-acting injectable, or sometimes it's about like logistical and administrative issues, like if, for example, somebody is getting an LAI through a patient assistance program and the medication arrives late, you then have to discuss things with the pharmacy, and you have to coordinate a nursing appointment. And there's this sort of logistical challenges, and making sure and trying to line up your appointment with a nursing appointment can sometimes be an issue. And then, another thing is if people are developing side effects while they're on the long-acting injectable, there can be sometimes a lot of concern because, the person's saying that they're having these side effects, but they also know that they have a long-acting injectable and that the medication is going to remain there for a while. So really, being thoughtful about managing the side effects of LAIs if people are having them, systematically asking about them. And I think that part of that really comes about like doing an appropriate, initial tolerability period and making sure the person's tolerating the oral version of it pretty well. In some situations that can be, a little bit more abbreviated or rushed, particularly on the inpatient unit. Like if somebody's about to leave the hospital and they've only maybe gotten a few days, that's a tricky situation. And sometimes the benefit of getting the LAI might outweigh the unknowns of, a briefer tolerability period. Another challenge that sometimes comes up is when people have persistent positive symptoms despite being on an LAI. So those are just a couple that kind of come to mind. I don't know.
Yeah, I really want to talk a little bit more about that, the persistent positive symptoms there. But I actually, I was hoping, I see this issue of this fear of side effects a lot. People will say, yeah, I can appreciate why you want me to take this, but what if I start to have side effects and this medication remains in my system for the whole month or however long the interval spacing period is, and I agree that sort of demonstrating oral tolerability is pretty important, from our end too, and making sure that they can tolerate it. But I'm wondering how you kind of handle that anxiety over side effects, because I suspect that's real for a lot of people.
Yeah. Like the idea of something being in the system for 2 weeks, a month, 3 months, 6 months, and not being able to, really, it's not just like you can stop the medication and then it kind of will go away. So it's a very, very real concern. And I like to talk about how the side effects that happen when people get LAIs are typically manageable. Like we're going to have a conversation about these. These are the ones to potentially expect. That doesn't make it more likely for people to develop them. So talking about, even how we're going to look at how we're going to monitor them. One of the ones that I think is a particular concern is tardive dyskinesia, because these are folks who have demonstrated oral tolerability to the medication and like things are often going along just pretty well. So, in the beginning, sort of talking about this idea that this is a possible side effect, we are going to be, looking at this at every clinical visit, and then we're going to be doing, more in-depth ratings at least yearly.
Yeah, I like that idea of really sort of putting it out there that you're going to thoroughly assess for these side effects and really laying it out there. This is how we're going to do it. I think can allay many people's fears. It's interesting, the patient that I was speaking about before, we've had conversations about switching to longer interval, long-acting injectables. And this issue of side effects is the thing that is really the holdup for him right now in terms of, considering, say, a 3-month or even a 6-month formulation. There's a real concern on his part. And, he's clearly showing that he's able to come in monthly, and it's not a huge push right now to go to a longer interval LAI. But I think that the side effect issue can come up in multiple types of conversations about having someone on a medication like this.
Mm-hmm. Yep. And I think the other side of that coin is, what if it runs out early? If it's a longer acting antipsychotic medication. And that's been a concern that I've heard from some of the patients I talk to. I think partially because of how troubling the relapses can be, and sort of developing a plan around that. Like, if the mild symptoms begin to come back, this is exactly what we're going to do. This is the plan. This is who you contact. Really, having it mapped out in as much as one can.
Yeah, those breakthrough symptoms, especially as you get to sort of the end of that interval period, it can be quite alarming for people. I mean, I think that fear that, are my symptoms coming back? What does this mean for me? What are we going to do about it? I think is really important to, like you say, to address it early and to make sure that they know exactly what to do in those situations. I'm curious how, I guess, and we could talk about breakthrough symptoms more broadly, but in that situation where you start to get early wear off of the effect of the LAI, how do you approach that? I think that's probably a pretty common clinical issue that comes up for people.
Mm-hmm. Yeah. Yeah. The things wearing off a little bit early. For that one, I think there's some relatively straightforward fixes, like if you know that there's, not something else that's contributing to it, and that it's pretty clear that it's a pharmacokinetic issue and that you're just not getting the drug level that you need to be at. I think there's some good strategies, often including, is there a way to kind of tide people over with some of the oral equivalent of the LAI, and thinking through, what dose would that make sense at? Part of the problem with that strategy is that, not everybody, but some people, adherence is a challenge in the first place, which is why, people on LAIs, and then you're proposing, let's add this other oral medication. But, I think a lot of times in my experience for people who take LAIs and they're having breakthrough symptoms at the end of the interval, taking some oral medication for a few days is not really, hasn't been a huge barrier. And sometimes it can be predictable that this is going to happen, and giving people some flexibility around, an extra week of oral medication can really, and allowing our folks to make some decisions around using some of the antipsychotic medications and really empowering people to, kind of do something about it. I think that can be useful.
Yeah, I think you bring up a really key point there, that being able to empower our patients to say, I need a little bit more, and I get to be the one to direct, when that happens, I think is really nice for patients to feel like they're in control and that they have the ability to have a little bit of extra oral medication to take when they have some wearing off symptoms. And I actually think that that's part of the engagement piece, is building that trust between you, the clinician and the patient, and to say, I trust that you're going to take this appropriately, and to be able to take it when you need it. I think that that's really important. Patients really, I think, respond pretty well to that in my experience.
I agree. And I think the other question or possible strategy that kind of comes out of this is then reducing the injection interval, instead of, for example, 4 weeks going to Q3 weeks. How has that been for you? How does that work out? Like, is that covered? How do people do with that?
Yeah, I've actually found that can be very helpful for people. I think from a coverage issue, it's been a mixed bag. Sometimes it's pretty reasonable, and you can clearly demonstrate that that this is necessary and important to achieve stability. But I do think that a lot of times reducing that interval can be a really nice way. I think the different pharmacokinetics and dynamics of these medications are complex, and though we have our target interval, some people may need it a little bit sooner. And I think that we need to be open to the idea that that's going to be important for somebody. I think one other thing that may be helpful there, and I'm curious if you do this ever, is using therapeutic drug level monitoring in order to show that the levels may be lower than what you would expect or hope them to be in order to achieve stability there. Is that something that you ever use?
Yeah, it is. Definitely in some cases. I think particularly when the LAI is running out a little bit early, you're not getting the response that you had kind of predicted that you were going to get. And then it's a very reasonable question to ask, like, is this a kinetic issue? And I think that sometimes there's clinical clues that will point you to this, and then using a level will help to give you some additional evidence. I think it's important to kind of put the level in the context of the broader situation, like the level is going to be a part of this sort of decision-making process. And, we probably don't use levels enough in sort of psychiatry and community mental health. And maybe that's changing to some extent. I think that they can be really valuable. Many of the common long-acting injectable medications have like a therapeutic response and then a range in which you would expect them to be working. And if they really deviate from that, then you may wonder if something else is going on. There's some excellent literature in the HEMP ASCP guidelines for therapeutic drug monitoring, which really kind of lay out what you would expect in terms of levels nicely. I like to get the level right before the next injection is due as a matter of I think that's probably the best time to get it, and you really want to wait until the medication has achieved steady state concentration after 4 to 5 intervals. But I think that the other issue that happens with the levels is that they can sometimes take a while to come back, and that's okay. I look at levels as you're sort of doing some detective work, you're trying to figure out this picture, and even if the level comes back a week later, it's going to give you some important information to help you in your decision making. Like, we're kind of playing the long game, we're working with people over time. And sometimes if the level comes back a little bit later, that doesn't really dissuade me from, not doing it.
Yeah, I think that's a really important limitation. But, I think that drug level monitoring, broadly speaking, is something I agree that we should be considering a lot more in psychiatry. It can be a really useful tool, especially when people continue to have these breakthrough symptoms that I think we've really, I think we're really talking about here. And I kind of want to stay here for a little bit because I think that this is really important. And I think key to recognize that these breakthrough symptoms of psychosis, even on antipsychotic maintenance, I think that we refer to this as BAMM, BAMM, it's actually not uncommon. I think that there was a study from Finland, lots of patients, over 15,000 people on long-acting injectables, and the incidence of this was over 30%. It was like close to like 32%, if I recall. So this is really important. I think pretty under-recognized, and I'm wondering, in your experience, how do you approach this clinically? Both, how do you talk to a patient about it? We build up these long-acting injectables as being the answer for folks, and then how do you start to work through what may be causing those symptoms?
I think an important part of it is sort of setting reasonable expectations and sort of opening the possibility that this is an option that might help. And sometimes it takes so much work to get to the LAI that it can be a disappointment if there's breakthrough symptoms. So it's a tough situation. But I think, first of all, like sort of couching the expectations appropriately is important. As you said, like breakthrough symptoms are a common thing, and I think that they're starting to get more recognition now, and I hope that there's more studies that are really looking at breakthrough symptoms, particularly around when during the injection cycle are the breakthrough symptoms occurring. There's still, I think, a lot of unanswered questions, but I think we know that it is kind of an under-recognized problem. I think in general, I kind of wonder about things like, what's the timing and the evolution of the breakthrough symptoms? Like, is this a new thing or is this an ongoing thing? Has it always been like this? Or is this, kind of newly developing? And if it's newly developing, then why? And are people having other issues that may contribute to some of these breakthrough symptoms? Is it other psychosocial stressors? Is it a relationship? Is it a change in job? Is it a loss of job? All these sorts of things. Is there, more expressed emotion in the house can definitely contribute to it. Are there medical issues that might be contributing to it? Are there, is the person taking new medications? Like, did they get a new medication or a new supplement? So those are a couple of the things I try to think about. Yeah, what are the things we could add to that?
Yeah, I mean, I think that those are pretty key. And certainly I think the workup is pretty robust, off the top of my head. I mean, I think, you may also be thinking about, are there any substances that people are using that you're not aware of? It's important to ask about that. Are there new medications? Have they recently seen their PCP, and maybe a new medication was prescribed for them that there may be an interaction? Certain labs may be helpful. Checking, thyroid hormone levels, for example, could be useful. But I think taking that broad approach, and I really liked how you brought up some of the psychosocial issues and things that really could be addressed through your work with the patient or through, various evidence-based psychosocial interventions, really trying to get people engaged in therapy, like cognitive behavioral therapy for psychosis. Maybe they may benefit from some focus on job or relationship issues. I think we need to be pretty open to a wide variety of things playing a role here. And I actually think one thing that is really important to think about, and I think the timeline, like you're talking about, is really key to this too, is really assessing for whether or not this is someone who might really benefit from a clozapine trial. We obviously do a lot of clozapine work in our clinic, and I think that, if someone is continuing to have breakthrough symptoms, despite being on an LAI, you've looked at all these other issues, really determining whether they may be someone who is, treatment resistant or clozapine responsive, however you want to refer to that. This may be a really good opportunity to consider whether someone may benefit from clozapine. I'm wondering what you think about that.
Absolutely. A couple of thoughts I was having about it too. It's like sometimes what happens as well, especially in early lack of response to an LAI, is that there was an improper oral bridge period, like maybe somebody didn't do the oral bridge period, and then you're sort of wondering why are they not reaching a therapeutic concentration, or you're not seeing the sort of clinical results of that. But I mean, you're right. I mean, you would expect people to have the so-called poorly named treatment-resistant schizophrenia. And, the studies show that in first episode patients, it's probably around 20%. And then if you look at larger groups of people who have had multiple episodes, you're looking more at 37%. So it's interesting that, in TRS, there appears to be a group of people who develops it over time. And when you're working with somebody, you may be noticing that they may be developing TRS over time. And I had a patient the other day who I think this kind of happened to. They had done really well on a long-acting injectable for maybe 7 years, and they decided that they wanted to go off of it. So we went very gradually over a year period. We reduced the dose extremely gradually. And then eventually he was off of it. He was doing well, maybe for about 6 months with no symptoms. And then it came back, and it came back in a very significant way. And he became, really had a lot of symptoms. We resumed the LAI, and now there's still a lot of positive symptoms despite being on the LAI. And I don't know and I think now, we're talking about clozapine. So there can be real consequences, I think, for some people to, and I think that we had good reason, to consider stopping, but also we were talking about the risks that, it's possible it might not work as well when we go back. So, this is also really important for early psychosis patients, I think, to sort of, for people who are, if they can get an LAI trial very early on, I mean, there's plenty of data to show that that's going to be helpful for them to reduce hospitalization, possibly change the course a little bit. But then also, that there's going to be certain people that are going to have TRS kind of right out of the gates. And with an LAI, you can really identify that much more quickly. So it really helps it really helps us get the number of antipsychotic trials down to 2 rather than 8 or 9, and a bunch of different stuff, and really introducing clozapine early on where it's probably going to be more effective in the first place.
Yeah, completely. I think that what's really nice about using the LAI and sort of that way of determining whether or not TRS is present is, it really guarantees you that someone is getting a full trial. They are on the medication. It is a good dose, it's an adequate dose, that they're taking it because they're getting the LAI. And if they're still having those breakthrough symptoms, I think you can feel pretty good about starting to have that conversation about clozapine. I think the point that you made at the very end there is probably, at least in my mind, the most important, that we need to identify these individuals early, because the best predictor of clozapine response is time to clozapine. And the longer that we wait, like you said, people are on 6, 7, 8 different antipsychotic trials before getting to clozapine. Your window is narrowing, and maybe even you're going over that sort of critical window when you really want to get people on clozapine so that it really is most effective. So I think LAIs are a really good tool for that as well. I think it's something that maybe we don't think about enough, in fact.
Yeah, absolutely. And we know that from studies like the pre-lapse study that, early psychosis patients will accept LAIs, and they'll both, be willing to consider an LAI, and then they'll the time until hospitalization is also reduced. So in some ways, it's kind of flipping this notion on its head that LAIs are sort of reserved for people who are maybe not adherent to medication, but instead, maybe this idea of just offering LAIs to everybody, and especially like if people prefer them.
Yeah, that's certainly been my experience. I think that it's very, I think, easy to get into your mind that LAIs are for patients who are not adherent, but I really think that we need to think much more broadly and really see the benefit of, like you said, offering LAIs to everyone. I think what you were just saying about the pre-relapse study and early episode patients, I think brings us back to kind of where we started, and that idea of connecting it to goals, and especially in a young individual who is, very early in their course of experiencing psychosis, really linking this conversation to getting back to school, getting back to work, having the relationships, meeting the goals of your life at that young age, I think is really key. And if we're not using LAIs in those situations, I think we're, at least in my experience, I think we're missing a huge tool in our armamentarium of getting people back to being functional and to living the lives the way that they want to live it. We really need to be thinking about these things.
Very much, Dr. Cotes and Dr. Goldsmith. And thanks to you, the listeners, for joining us. As a reminder, to view the full certified educational program, Liberating Stability, a deep dive into long-acting injectable antipsychotics, please click on the link in the show notes. As always, thanks for listening.